with proven safety and efficacy. However, it entails complications like any other surgical procedure. A rare but very serious complication is post-LASIK ectasia, which is characterized by the progressive thinning and steepening of the cornea, resulting in loss of best corrected visual lines. Again, the answer to this question is yes, if we ignore a fact like this photo here, for example, showing a person coming asking for LASIK and he is having an inferior steepening in his cornea, and he is a keratoconus suspect individual. If we proceed with LASIK, we might end up with ectasia, and this is a nightmare. However, if we respect the rules وما جازفناش بالعيان بتاعنا وحصل ectasia, then this is not a nightmare, it's just a complication, and complications do happen. Many authors have spoken before about these facts, or in other words, these risk factors which will lead to ectasia post-LASIK. One of the most famous is Randleman J. Bradley, and the Randleman ectasia risk score system was introduced in the year 2008, and it considered 5 parameters, or in other words, 5 risk factors. The first risk factor is the corneal topography, the second one is the residual stromal bed thickness, or the RSB. The third factor is the age, the central corneal thickness, as well as the mean refraction spherical equivalent, or the MRCE, or in other words, the degree of error the patient is having. The 5 parameters once more, or the 5 risk factors, being the corneal topography, the most important one of which. The second factor is the residual stromal bed thickness, age, central corneal thickness, and finally the manifest refraction spherical equivalent. The corneal topographical patterns are the most important, and they carry the highest risk among all other risk factors, and it was found that nearly 50% of ectasia cases have shown to have definitive corneal topographical abnormalities. These patterns could either be abnormal topography or suspicious topography. Abnormal topography, like we can see here in this photo, this is a keratoconus patient, as well as also formed thrust keratoconus with an IS, or inferior superior value, of 1.4 diopters or more. Another photo showing us PMD, or pellucid marginal degeneration, with its inferior corneal steepening. Both should be excluded from doing LASIK. Suspicious patterns, on the other hand, include inferior steepening, which is defined as the inferior steepening in some direction of 1 diopter or more, but with an IS value of less than 1.4 diopters. What is the IS value? The IS value is the average refractive power difference between 5 inferior points and 5 superior points, both 3 millimeters from the center of the cornea, and all the points are at 30 degrees intervals. This is defined as the inferior superior value. Of course, this photo is suspicious, and we should not proceed with LASIK. Another suspicious pattern is the asymmetrical bow tie, which is defined as asymmetrical steepening of less than 1 diopter in any area or in any direction. In addition to the previous patterns, one could also and should also give weighted consideration to patients or to persons coming with significant topographical asymmetry between both eyes, although both eyes may not meet the criteria of abnormalities. However, asymmetry should be taken in consideration, like the photo in the down part of the slide. The second factor is the residual stromal bed thickness, which is also a very important factor, and it's actually a continuous variable, with the risk of ectasia increasing with decreasing the residual stromal bed. كل ما هنسيب residual stroma أكتر، كل ما أنت بتبعد عيانك عن فرصة الإكتازيا. This is because of the fact that LASIK reduces the structural integrity both by decreasing the overall load-bearing tissue، أنت بتاخد من الآخر من الكورنيا بتاعت العيان، and by shifting also the load-bearing responsibility to the posterior part of the corneal stroma. And it was found that the stroma, the corneal strength mainly, lies in the anterior 40% rather than in the posterior 60% of the corneal stroma. واحنا في الليزك نشتغل طبعا على الانتيريور part. مش بس كده، الcornea flap contributes very minimal to the tensile strength of the cornea after LASIK. عشان كده كل ما هنسيب RSB أكتر، كل ما هتبقى في السيف سايد أكتر. The third parameter is age، ودي عليها الحقيقة debates شوية، بالذات اللي وصفه راندلمان. Young age has been identified as a risk factor for ectasia, even in the absence of other significant risk factors, and this could be explained by the fact that the tensile strength of the cornea increases with age. Finally, the central corneal thickness, the mean refraction spherical equivalent, and the RSB, all of them are interrelated, with the RSB being the most important factor of them. طبعا لما هنلاقي في الأول corneal thickness كبيرة ده بيبقى against شوية risk of ectasia، والعكس لما هتلاقي error of refraction عالي بالذات لو more than minus 14 diopters, this is a very high risk for developing ectasia post LASIK. However, it was also reported lately that ectasia has been developing also and occurring as well in cases with low errors. So it's apparent that things are still not yet clearly understood. This table shows us the ectasia risk score system. On the left side we have the parameters of the system, and on the right side we have the points. Of course, the first parameter, which is the most important one, is the topography. If it's abnormal, it carries high risk with 4 points. If it is only showing inferior steepening, this is 3 points with moderate risk. Asymmetrical bow tie carries 1 point of risk, and normal and symmetrical bow tie carries 0 risk. The residual stromal bed, if it's less than 240, this is high risk. If it's 300 or more, this is of 0 risk. The age, from 18 to 21 years of age, it is of moderate risk, and if it's 30 or more, it is of 0 risk. The central corneal thickness less than 450, high risk. 510 or more, it is of 0 risk. And finally, the MRSE, if it's minus 14 diopters, this is a high risk person, and minus 8 or less, this is of low risk. Other risk factors also include family history of keratoconus, as well as refraction instability, and also male gender, and these risk factors should be considered especially in cases of borderline persons. طيب what's against Randleman؟ الحقيقة one major criticism against Randleman is age, because لو احنا بصينا على التيبل ده مرة تانية هنلاقي ان اي شخص جاي يعمل ليزك ما بين سنة 18 لسنة 21 is considered to be of moderate risk. However, ectasia is not that evident in this age group. يعني ممكن تحصل في age groups تانية، مش شرط يكون 18 to 21. مش بس كده. Another criticism is that ectasia also occurs in eyes without any known risk factors. يعني احنا ممكن نكون شغالين على normal topography وسايبين RSB 300 أو أكتر، والايج بتاع العيان 30 أو أكتر، والcorneal thickness من الأول أعلى من 510 والايرور مش عالي، ومع ذلك يحصل لك برضه ectasia. That's why it's apparent that many underlying factors are still not yet clearly understood. ومن هنا جه another screening system was introduced by two authors, Bellin and Ambrosio. Ambrosio, the Brazilian author, Renato Ambrosio. This is called the Enhanced Ectasia Susceptibility Screening, or the EESS. This study depended more on comprehensive analysis of the topography, the topometric indices, as well as the pachymetry, rather than depending on a single map of the cornea. That's why it carries 90% sensitivity and 92% specificity. Most of the surgeons nowadays are using actually both in assessment of the LASIK person, both the ERSS and the EESS. Type, how often do we meet ectasia in our life? Actually, the percent of incidence is not that high. We are talking about range from 0.041% to 0.6%. However, members of the International Society of the Refractive Surgery and the American Academy of Ophthalmology have stated that at least 50% of surgeons have met ectasia once in their lifetime. The timeline over which ectasia develops is quite variable. The reported average onset is 15.3 post-op months, with 25% presenting within the first 3 months, and more than 50 presenting within 12 months. The earliest case being detected at 1 week post-LASIK, and the latest at 62 months or almost 5 years post-LASIK. أي حد بيبقى شاكك إن هو عنده حالة ectasia بيقعد يدعي ويقول يا رب تبقى regression. فالسؤال ده is very important. Is it really ectasia or just regression? This is because of the fact that ectasia will present early with increasing myopia and astigmatism, which may mimic regression. And it is very important, it's actually imperative to rule out the possibility of early ectasia before any enhancement surgery. انت لو شخصتها regression ايه اللي هتعمله؟ هتعمل more LASIK ablation, and at that time you will invariably make the situation worse. طبعا slit lamp examination you can differentiate, but you need a very advanced case of ectasia to be seen by slit lamp, like the photos here. On the left side we have lower ectasia, and on the right side we have an upper one. However, if you follow up your patient and do more diagnosis, if you found that the irregular astigmatism is increasing with more loss of best corrected visual lines, you are more with ectasia than regression. Also, the topography will be of great help. It can show decreased corneal thickness and more inferior steepening, and this is of course more with ectasia rather than with regression. Another tool of diagnosis which is becoming popular nowadays because it has some advantage over other imaging modalities is the anterior segment OCT. It can provide us with very helpful, high-quality, three-dimensional cross-sectional images of the anterior segment, as well as very reliable pachymetric maps. We can see here thinning over the ectatic part seen by anterior segment OCT. This photo here shows a weak part of the cornea that is ectatic, and we are using a therapeutic contact lens over the cornea here. And this is the photo after treatment of this condition with two Intex rings. I hope they are apparent, the arrows. The blue arrows here are showing to the place of the ring. The red arrows are showing the therapeutic contact lens, the anterior and the posterior surface of the lens. The green arrow is pointing at the fluid-filled space between the therapeutic contact lens and the cornea, and finally the white arrow is showing the posterior surface of the lasik flap, which never heals. احنا ممكن نرفع ليزك فلاب several years up to many years post ليزك عشان تعمل ريدو. انا مره رفعت حاله كانت عامله بقالها 12 سنه ورفعتها وكانت يعني it was very simple procedure يعني. السؤال الأخير I consider it a very hot topic is, can we treat ectasia like keratoconus? Yes, yeah, the answer is more or less yes. Randleman believes it's totally the same. Modalities for treating ectasia is exactly the same as keratoconus. Non-surgical treatment and surgical treatment. In non-surgical treatment, of course, we don't consider glasses at all. By non-surgical treatment, we mean contact lens options, and it was Sir John Herschel back in the year 1845 who was the first to propose a detailed description of a contact lens. And of course, the RGPs, or the rigid gas permeable contact lenses, being the most important in dealing with ectatic corneas, because they have the ability, as we can see here on the left side of the photo, that these lenses are able to mask the underlying irregularity and provide us with a new refractive surface of the eye, but again its use is very limited. This flowchart and this table here helps in the decision of which optimum contact lens to be used depending on the degree of the cylinder as well as the tolerability for the rigid gas permeable contact lenses. The surgical modalities are more commonly used. Better to start with a non-invasive modality like cross-linking, which is a minimally invasive technique that uses riboflavin and ultraviolet A irradiation to increase the corneal rigidity. It actually augments the biomechanical strength of the cornea by inducing interfibrillar links in the corneal stroma, with the results being very promising, but still the poor vision quality in such patients remains largely unchanged, because it is a stabilizing rather than a corrective tool. Recently, the major advance in cross-linking is the introduction of the Avidro KXL, or the fast cross-linking, that decreased the time of the procedure from 1 hour to several minutes by increasing the ultraviolet A irradiation power. Another line of treatments is the intracorneal ring segments, and these, on the contrary to the cross-linking, they are able to decrease the astigmatism, and they are able to increase the visual acuity to acceptable limits. And this table here shows the comparison between the three commonly used intracorneal ring segments, the Intex and its modified form Intex SK, the Ferrara and the Kera rings as regards their arc length in degrees, the cross-sectional shape, the thickness, and the inner and the outer radii in millimeters. The rings can induce flattening of the central and the peripheral cornea, and it is the diameter of the ring that determines how much cornea will be flattened. The thicker the segment and the smaller the diameter, the greater the effect the ring will have. Several combination procedures have also been suggested. One of the very famous combination procedures, is the combination of corneal cross-linking together with the intracorneal ring segments, because they both have synergistic effects on treatment of ectatic cornea, they can be either performed simultaneously or sequentially. And this study here shows that when Intex was performed alone, there was an improvement of vision, about 1.9 Snellen lines of uncorrected visual acuity and 1.7 of best corrected. However, when Intex was followed by cross-linking, there was an additional 1.2 Snellen lines of uncorrected and 0.36 Snellen lines of best corrected vision. Also, the decrease in the spherical, the cylinder, the mean K values and the steepest K values were more when Intex was combined with CXL rather than when Intex was performed alone. Another combination procedure, which is also gaining very good repetition, is the Athens protocol. في papers بتتكلم ان هو بيتعمل في البوست ليزك ectasia. This is the combination between simultaneous topography guided PRK together with corneal cross-linking, and this photo shows the improvement of an ectatic cornea before and after Athens was performed. This table here shows also the improvement of different parameters. The mean refraction increased. It was before the operation 20/131, and it improved to 20/46 post-operative, with this bar chart showing that at least 50% of the patients have gained one or more lines of best corrected visual acuity. Finally, keratoplasty with its new technique. It's not that new, but it's very commonly done nowadays. It's the DALK, or the deep anterior lamellar keratoplasty, where we remove the tissue of the recipient, the epithelium and the stroma down to descemet membrane, replacing it with donor tissue, leaving the descemet membrane in a hope for decreasing the rejection of the corneal graft, with this map showing a patient with post-LASIK ectasia before and 2 years after DALK was performed. Finally, the keratoplasty, the penetrating keratoplasty, being the last tool when all other options have failed, or the first line of treatment in cases with advanced post-LASIK ectasia patients. At the end, I would like to stress on the fact that managing post-LASIK ectasia is a true challenge for all corneal surgeons. Each case should be individually assessed for the etiology, for the stability, for the potential visual acuity, and for the realistic goals after surgery. Better to perform the therapeutic measures you have in hand in a stepwise fashion, going from the minimal, the least invasive, to the more sophisticated measures, and please don't ignore the risk factors. If you ignore the risk factors, you will meet ectasia a lot in your life. If you do not ignore and you follow the rules, inshallah, ما تجيش لحد خالص. And thank you very much.